Doctors removed a fish from a patient suffering from abdominal pain. The fish was still wriggling after removal, and the patient's liver was one-third eaten. One morning, Dr. He, the head of gastroenterology, stepped into the operating room to perform surgery on a patient. The patient had been dealing with intermittent abdominal pain for a week. A CT scan at a local hospital revealed left hepatic lobe intrahepatic bile duct stones and left lobe bile duct dilation with left hepatic lobe atrophy. The local doctors diagnosed bile duct stones with dilation and recommended immediate surgery to remove the stones. The next day, the patient was admitted to a hospital's gastroenterology department for surgery. Dr. He noted that the patient had their gallbladder removed 20 years ago due to gallstones. Given the patient's medical history and previous diagnosis, Dr. He conducted further examinations. An MRI showed significant dilation of the intrahepatic bile duct in the left hepatic lobe, with multiple granular shadows inside and a strip-like shadow in the common bile duct. Suspecting it might be more than just bile duct stones, Dr. He decided to perform an endoscopic retrograde cholecystectomy pancreatography ERC to determine the nature of the blockage and remove it if it was a stone. On the third day of hospitalization, after ensuring there were no contraindications and completing preoperative checks, Dr. He performed the RCP. As a routine procedure, Dr. He was well experienced with it. He inserted a flexible tube with a light source and camera into the patient, searching for the blockage on the display. When he reached the lower part of the common bile duct, the display showed a shocking scene, a grayish-brown, fish-like organism moving around. As the surgical instruments touched it, it moved more vigorously. A swift decision, Dr. He decided to remove it. Using a stone retrieval basket, he extracted the creature and placed it in a disposable treatment dish. The team discovered it was a 3.0x.5 centimeters oval-shaped live parasite, still wriggling actively. After removing the parasite, they performed another bile duct imaging, confirming that the blockage was gone. The surgery ended, and a nasal bile duct drain was left in place. The surgery was over, but the team now faced a new challenge. What was this creature, and how should the patient be treated? Rare and unusual? Experts joined forces. This is most likely a parasite, but we need to consider the patient's epidemiological history, the team said. After the patient woke up, they learned he had lived in the mountains for years, often drinking untreated spring water and eating raw herbs. Identifying the parasite was crucial for targeted treatment. Despite their experience, the team had never seen anything like it. They organized a multidisciplinary consultation, including gastroenterology, hepatobiliary surgery, infectious disease, and pathology departments. They concluded that the parasite was likely a giant liver fluke, Fasciola hepatica, which is much larger than typical liver flukes. The patient had a history of drinking contaminated water and eating raw herbs, which aligned with the infection route of the liver fluke. Literature searches showed few cases of this parasite, with individual reports from places like Turkey and Iran. Previous cases described much smaller parasites. Given the patient's left hepatic lobe atrophy, the team decided to start antiparasitic treatment quickly to prevent further liver damage and recurring cholangitis. However, the internationally recommended drug for this parasite was not available for human use in China. The team found that traditional antiparasitic drugs like albendazole and praziquantel were less effective. The recommended drug, triclebendazole, was used primarily in livestock in China. After a multidisciplinary discussion, Dr. He suggested trying a combination of albendazole and praziquantel. The patient was given 0.6 grams of albendazole and 0.6 grams of praziquantel every 12 hours for 2 days while being closely monitored. During this period, multiple stool and bowel tests showed no eggs, indicating effective treatment. A week later, the patient's abdominal pain and nausea subsided, and he was discharged. At a follow-up 2 months later, the patient had no discomfort, but an abdominal CT still showed left hepatic lobe atrophy and bile duct dilation. Dr. He emphasized the importance of early detection and effective treatment to prevent misdiagnosis. For this rare case, Dr. He shared his experience and thoughts for clinical reference. In China, human liver fluke infections are extremely rare, often found post-mortem. Diagnosing this condition is challenging due to the irregular distribution of eggs in stool and bile, and the low sensitivity and specificity of antibody and antigen tests. Imaging may show signs like cluster sign, a tunnel sign, but these are rare and nonspecific. Early symptoms are not typical, and various diagnostic limitations lead to a high rate of misdiagnosis. The RCP is considered the gold standard for diagnosing liver fluke infections, allowing for the removal of parasites and examination of bile and duodenal contents. Precautions in daily life include proper food preparation, separating cutting boards for raw and cooked food, avoiding raw water in food, and regular deworming of livestock.